So I thank Dr. Sahil for including me in this course, and I'll just be briefly covering aging of the face and some of the basic anatomy along with the danger zones based on certain procedures. So the basic features of aging that we commonly address are volume loss, fat loss, superficial lines and wrinkles, and the most important thing is that we need to keep in mind is there is also some amount of bony resorption which takes place, as well as overall descent of the face. So with respect to bony resorption, in the lower face you can see how the angle of the mandible increases along with the age, and in the orbital region you have bony resorption mainly in the superonasal region and the inferotemporal region. So the area which is sort of the where the fat lies, where you can see in the younger individual, it is sort of well kept within the orbit, and in the older person it starts becoming prominent. And also where in the older person the lid cheek junction also sort of starts getting eroded because of the bony resorption. Now the other thing we address usually is the aging around the mouth. So here you can see the elasticity of the skin gets lost much sooner than what the orbicularis ages. So the orbicularis action becomes a little more prominent than what the skin can take. And the other thing here you need to note is the temporal hollowing. So with age you see this temporal hollowing along with the other changes that I mentioned earlier. So in a 30-year-old individual or somebody between 30 to 40, you generally start seeing the wrinkles forming. So not just the static dynamic wrinkles that happen with facial expression, it's also the static wrinkles which start appearing with the age. In older individuals, you will see that the brow starts to descend. You can see that the tear trough elongates, and they start developing perioral lines. And somebody in their 50s, they tend to have again a deeper tear trough, and along with this the nasolabial folds start becoming more prominent. So these are things that we keep addressing one by one. And somebody above 60, you can see the prominent jowls that start to develop because of the overall facial descent, and all the changes that we mentioned till now, they become more and more exaggerated. Now when we assess the face, we look at the facial shape with respect to the cheek and the chin, the length of the forehead, the brow shape and the height, the lid height, and the nose and lips is something that we don't commonly address at our level, and the skin texture and the clarity. Now you need to keep note of where all the fat compartments are. So this first diagram shows all the superficial fat compartments, and the second diagram is all the deep fat compartments. So these are the areas which we generally target when we want to do volume augmentation. And with respect to the muscles of the face, what we most commonly address is of course the procerus and the corrugator for the frown lines or the 11s, the frontalis muscle for the horizontal frown lines, and of course the orbicularis oculi. Along with this, when you need to look at the lower face, for example the masseter injections, you need to be careful of this risorius muscle. Okay, so this can change the shape of the smile if at all the injection tends to migrate to other regions. So once we talk about the muscle, we would immediately talk about the wrinkles. Like I mentioned, the wrinkles which are along with expression, and then along with which are static and always present. So it keeps increasing with age, of course. So as you inject botulinum toxin in patients who are older, they would need several more sittings for the aging or for the static wrinkles to appear less. Now these are the most common areas that we address. So like I mentioned, the glabular lines, the frontal lines, this superior sulcus hollowing, of course, the tear trough, the crow's feet, the infraorbital hollow, this malar projection, the nasolabial fold, and at times the smoker's lines. Now when it comes to the safety of these injections, it's important to know the anatomy of the vessels that come across in this region. So not only do you need to know which vessels are where you inject, you need to know where you can inject superficially, where you need to inject deep, that is for the fillers, and where the anastomoses are, because these are the areas which are most commonly associated with embolic choking. So like I mentioned, so you can see here, these are the internal carotid artery vessels, and these are the external carotid ones. So in between the areas where you can get these embolization, because these are the areas where these two arteries meet. And this again, this diagram I will be discussing later. Now, why the lymphatic system is important now is because as people age and they get more and more filler injections done, so they develop layering of fillers. And if a patient goes to one person and gets fillers, and then goes to the next person and gets more fillers, without leaving adequate amount of time between both the filler injections, they tend to develop lymphatic stasis, which causes long-term swelling. And this doesn't respond generally to even hyaluronic acid injections. So it's important nowadays to make sure if a patient already has fillers in their face, to get an imaging done or an MRI done, and that will help you locate the location of those fillers, so that you don't go and inject more where it's not required. And it's important again to keep a note of the male female characteristics, and the where you need to do what augmentation. So the eyebrow shape and the projection of the forehead, these things are much different compared to the female in a male. So you don't want to cause a large arch of the eyebrow, and you address these things based on the characteristics. Now, these are the areas which are again prone to these embolic phenomena because of these arteries converging. So in this glabellar region, we try as far as possible not to go in with fillers. And whenever people are injecting fillers in the nasal bridge and nasal tip, they have to be very careful not to cause necrosis. So injections which are within 1.5 centimeters of the superior orbital rim, you would have superficial injections because the vessels lie deep in this area. And above that, you would have deeper injections to avoid the vasculature issues and reduce pain. Now, along the temple, you have the superficial temporal artery. So that is one danger zone, and you need to palpate that and be careful where you inject. And here the infraorbital foramen lies here. So you can again have issues with embolization here. So you inject with a cannula ideally. However, if you are injecting deep and just over the periosteum, you can even inject with a syringe, with a needle. Now again, along the lateral zygomatic arch, you need to keep it along the bone, but this is a low risk area. So you don't have to be too worried about this. You can inject deep in this area as well. And the other danger area is the nasolabial groove. So again, you can use a cannula in this area because cannula is blunt and would prevent an injection intravascularly. Now, Allergan has given this outline of where you should inject, but again, you'll have to customize it based on where the patient needs treatment. So you can use these codes to make sure that you document where you're planning to inject. And this shows the danger area. So this CK3 is a danger area, again, where I mentioned the infraorbital vessels are. And this is an area where you have to be very careful. So you can either put in a cannula here and turn the cannula towards where you want to inject, or you can inject directly over the periosteum for the tear trough. Now, why are we being so careful about these injections is because you can have an anterograde embolization, so that would be towards the superficial vessels, which can cause a reduced perfusion, blanching and severe pain, in which case you stop injecting and massage the area and make sure that they don't develop necrosis. And the other thing is, of course, a retrograde embolization, so towards the central retinal artery. So you would have visual loss if this took place. So in these conditions, there is a controversial talk about retrobulbar hyaluronidase injections, but what actually works is the superficial injection. So for example, this is a patient who had issues in the mandibular injection of filler, and under an ultrasound guidance, they were able to re-establish flow within about an hour or so, because once you inject the hyaluronidase, because it's a hyaluronic acid injection, you can re-establish flow. So that was just a rough outline on basic anatomy and danger zones, and I'll just hand it over to Dr. Adit.
Thank you so much, Dr.